opportunity to present the topic of valve stents and coils post-procedure imaging of endobronchial interventions to you all. I am Dr. Saboo from University of Texas Southwestern Medical Center in Dallas. In next 30 to 45 minutes, we will be talking about the imaging of the endobronchial interventions. I have nothing to disclose. I would like to thank my colleagues, Dr. Ann, Dr. Abara, Dr. Rena Purkar, Dr. Azok, and Marulus for giving some of the slides on this presentation. In next 30 to 45 minutes, we will touch base on the indications for the endobronchial interventions, followed by the imaging findings and expected follow-up findings and complications related to these procedures. Just a brief outline of what the bronchoscopy looks like and how it was developed. It was first developed in late 1800s, and subsequently flexible bronchoscope was introduced in 1960. And in the late 1900s, the endobronchial ultrasound was developed. Recently, in 2006, electromagnetic navigation bronchoscopy was developed, and biopsy procedure related to that were developed. These are the pictures of the flexible diagnostic and the therapeutic adult bronchoscope. This slide from the radiographics just to highlight the importance of types of bronchoscope and where this can reach is shown. What we see here is that rigid bronchoscope can reach up to first to third order bronchi, meaning like the third order bronchi would be interlobar bronchi, whereas the flexible bronchoscope can reach up to fourth, which is segmental bronchi, to sixth order bronchi, which is subsegmental bronchi. Ultra thin flexible bronchoscope can reach up to 7th to 9th order bronchi, which are the subsegmental bronchi. The important point to remember here is these days most commonly used bronchoscopic procedure is flexible bronchoscopy, and ultra thin flexible bronchoscopy is typically used in pediatric patients or if there are more peripheral lesions. So in the next subsequent slides, we'll first go over the diagnostic interventions and then we'll go over the therapeutic interventions. On these slides, what we show is there are 4 major diagnostic endobronchial interventions, which includes bronchoalveolar lavage, which is typically done for localized and diffuse lung diseases, and we'll go over that in detail on subsequent slides. Typically what we do is obtain culture and cytology with this procedure. Complications related to this procedure are minor, which includes pneumonitis, bleeding, and bronchospasm. Followed by that is brush biopsy, where we obtain samples for cytology and culture. Fine needle aspiration, again for cytology, and endobronchial ultrasound for tumor staging. The complications related to them are similar to like that of any endobronchial procedure, which would include bleeding, infection, and pneumothorax. First, let's look at bronchoalveolar lavage and how it is done. But before how it is done, let's see how the imaging appearance look like after you do this bronchoalveolar lavage. So image on the left shows pre-bronchoalveolar lavage X-ray, which shows looks like normal radiograph, followed by a bronchoalveolar lavage procedure which shows opacities in the right middle lobe in this 62-year-old man, and these opacities are expected from following the lavage related to saline washings that are done in this procedure. So basically, what are the indications? In localized diseases, it includes infections. For diffuse diseases, it includes ILD like sarcoidosis, eosinophilic pneumonia, hypersensitive pneumonitis, usual interstitial pneumonia, occupational lung diseases, and malignancies. As far as the localized diseases are concerned, what you lavage is usually involved segments, but for diffuse lung diseases, it is right middle lobe or lingula that is the site for lavage. How do we do this procedure? Why do we need to know that? And it is basically bronchoscopy is waged in a segmental or subsegmental bronchi, and then the saline boluses are instilled through the bronchoscope and subsequently aspirated from the scope. Up to 100 to 150 ml of saline is instilled during this procedure. And as I mentioned, we are expected to see some opacities following this procedure, and which is totally normal. And this will resolve on the subsequent radiographs. So we'll go over, try to identify the pathology on this radiograph. I'll give you a few. And what procedure would we need to do via the endobronchial procedure for this entity. As you have seen, this is a 54-year-old man with chest pain and cough, and there is a nodular opacity in the right perihilar region, which we can see here and better seen now with these arrows, and we can see on the lateral view very well. This turned out to be right mediastinal carcinoid, and how was this approached? So basically, after the radiograph CT scan was done to assess where it is located, and subsequently endobronchial ultrasound guided biopsy was performed, and which turned out to be a right mediastinal carcinoid. And as you can see on this bronchoscopy image showing a carcinoid lesion in the right mediastinal bronchus, and subsequently post FNA biopsy appearance on the bronchoscopy. That brings us to what are the parts of this endobronchial ultrasound and what we see. So it's just like any other ultrasound probe, and this shows the picture with the inflatable saline that provides a acoustic window for its approach. These are the needles that are used for endobronchial ultrasound guided aspiration biopsy. The normal station 4 lymph node which was seen with the preoperative endobronchial ultrasound. And this slide shows from the literature what nodes can be accessed through which procedure for sampling. For example, transbronchial needle aspiration without endobronchial ultrasound guidance can approach station 4, station 5, 7, and 10 lymph nodes. 10 is the hilar node, and as well as the 11, which is the interlobar region. Whereas endobronchial ultrasound transbronchial needle aspiration can go up to station 12 nodes, which are more peripheral, and also upper paratracheal nodes, which are station 2 lymph nodes. Endoscopic ultrasound, which is through the esophagoscopy, can approach lymph nodes which are adjacent to the esophagus, that is station 8 lymph nodes, and station 5, which are the subaortic lymph nodes, and 8 and 9 lymph nodes. So how does endobronchial ultrasound help as compared to routine transbronchial needle aspiration via bronchoscopy? It basically increases operator's confidence and it increases the yield of the sampling of the central mediastinal lymph nodes, and it is also used to access the peripheral sites of nodes like typically interlobar, lobar, and then hilar locations. So I'll give you a few seconds to look at there is complication related to bronchoscopy, therapeutic bronchoscopy, diagnostic bronchoscopy on this radiograph. And as you must have noticed, there is a small right apical pneumothorax. How common is the pneumothorax? So basically it's quite uncommon. 0.1% is the incidence of pneumothorax after diagnostic bronchoscopy. At our institution, we routinely perform radiograph after any bronchoscopic procedure. There are recent guidelines, however, which mention from British Thoracic Society to do chest radiograph if only the patient is symptomatic, but practice varies based on institutional practice. I will not go in details of the chest CT virtual bronchoscopy, but briefly mention that with virtual bronchoscopy you can get pictures to look at the area of narrowing and how it is useful. We'll go on the subsequent slide. These are coronal and sagittal reconstruction showing tracheal stenosis, and you can see it on virtual bronchoscopy image as well. So it basically provides the roadmap of the tracheobronchial tree, and so that optimal path for bronchoscopy can be approached, and also helps to identify the optimal biopsy sites, and as well as try to identify the sites where the needle has to go so that the appropriate target is hit. This is something which is upcoming and has been used at advanced centers for biopsy. This is sort of a CT-guided electromagnetic navigation bronchoscopy with biopsy, and I will go on the indications of this on subsequent slide, but let's take an example. This is a 59-year-old man with laryngeal cancer, post-electromagnetic navigation bronchoscopy biopsy, and also patient underwent brushings and lavage during this procedure. What we see on the coronal CT images are the two ground glass opacities, but note they are peripheral, and so therefore approach for this is very important. Either you can go percutaneous CT guided biopsy, or you can go through the electromagnetic navigation. And this is the radiograph post-biopsy, pre-biopsy, and the post-biopsy. Post-biopsy shows expected findings related to lavage and also some hemorrhage from that procedure. This is a picture of the endobronchial brush, how it looks. So when do we do this electromagnetic navigation bronchoscopy? It's typically done for peripheral lung lesions and as well as focal lung lesions as an alternative open lung biopsy. How do you do it? So basically, peripheral, first of all, you acquire a CT scan, and then peripheral lung lesions are localized via the electromagnetic field over the chest, and that enables biopsy via bronchoscope. It is just like similar to the left atrial appendage procedures that are performed for its occlusion. What happens is there is a co-registration between the landmarks within the subject and the subject CT and the virtual bronchoscopy dataset, which is performed with electromagnetic sensors. And subsequently, bronchoscope navigates the predetermined path to reach the target lesion. The major disadvantage of this procedure is cost and limited availability. With that, we'll turn to some other procedures which are done. For example, take this patient with 25-year-old female with pulmonary hemorrhage presenting with dizziness. What you see on the radiograph on the left is the diffuse consolidation in the left hemithorax and opacity in the right as well. And so this patient on bronchoscopy had large clots in the central bronchi, and there was active site of bleeding in the right upper lobe bronchus. So there is some procedure done, and I'll give you a few seconds to look at those images. So as you must have seen, there is a catheter, and this was basically an endobronchial blocker which was placed in the right upper lobe bronchus to occlude the site of bleeding in the right upper lobe. And the bronchoscopy image shows the blood in the right upper lobe bronchus. Let's switch gears and turn on to the therapeutic endobronchial interventions. There is a long list, but I tried to summarize it here on this slide, and we'll bring up this slide on subsequent slides as well, just to highlight where we are. We'll start with the endobronchial valves, which is sort of nowadays increasingly used, and we see it very often at our institution. It is basically indicated for air leaks, bronchopleural fistulas, and heterogeneous emphysema. The complication related to that would be similar to like any bronchoscopic procedure, which is like hemorrhage, pneumonia, pneumothorax, and particularly related to valves would be COPD exacerbation. So let's take an example, and then we will go over the way it works and why it is indicated. So this is a 58-year-old woman with emphysema and refractive pneumothorax. What you see on the radiograph, the patient has chest tube, and there is a right pneumothorax, large subcutaneous emphysema. Patient underwent a procedure for that, and as you can see, there are 4 umbrella-shaped valves in this patient in the central bronchi, and these were the endobronchial valves which were used in the right central bronchi to treat this refractive pneumothorax. So that brings us to an interesting topic, which is bronchopleural fistula, and their etiologies would include most commonly related to complications from thoracic surgeries, which include lobectomy, pneumonectomy, or maybe related to trauma. Also, they can occur following infection, especially necrotizing pneumonias, tuberculosis, or empyema. Treatment for bronchopleural fistula, depending on the type. For central fistulas, if they have communication with the central bronchi, would include surgical ligation or bronchoscopic occlusion. For the peripheral type of fistula, which are smaller, they can, approaches include bronchoscopic albumin glutaraldehyde tissue adhesives, cyanoacrylate glue installation, endobronchial valve placement, or coil placement. That brings us to the mechanism of action and purpose of these endobronchial valves. As I mentioned, the valves are used for air leaks and bronchopleural fistula. Currently in US, it is FDA humanitarian device exemption for this procedure. They are also in clinical trial phase for lung volume reduction surgery. And the way the valve works, as you can see on this image, it allows one-way flow of the air and secretions, meaning it does not allow them to flow on inspiration through them, but it does allow them to move in the from inside out on the expiration. And that way, the main purpose of this procedure of treating air leaks and bronchopleural fistula as well as lung volume reduction is taken care of. So basically, there are 2 designs of these endobronchial valves. One is duck-billed, which is EBB valve, as shown in this example. And as you can see, it is made up of nitinol self-expanding tubular mesh, which is covered with silicone membrane. Another type would be umbrella-shaped valves, which is IBV valves. Let's take another example of these endobronchial valves. In this patient with cystic fibrosis, what do you see? Extensive cystic fibrosis changes with bronchiectasis and reticulonodular opacities in both lungs. There is a large refractive pneumothorax on the left side with the pictal catheter. Patient underwent endobronchial valve placement, And as you can see on this insert image showing the endobronchial valves, and the pneumothorax did decrease following this procedure. And better seen on these MIP images, the endobronchial valves in the distal left main bronchi. That brings us to another endobronchial procedure that is done for yearly. This is a 70-year-old man with persistent bronchopleural fistula following left pneumonectomy. And as you can see, patient had left pneumonectomy and there is a large left hydropneumothorax, and that was due to left bronchopleural fistula. This is a fluoroscopic image trying to show some procedure was done for this, and subsequent image 3 months following that procedure shows there is a endobronchial coil in the distal left main bronchoscope following left pneumonectomy, and that did decrease the left hydropneumothorax and also decreased the bronchopleural fistula. Let's take another example. This is a complex case. Patient had right upper lobectomy via robotic approach for adenocarcinoma of lung. Patient developed right middle lobe related bronchopleural fistula and large hydropneumothorax. As you can see on these images, there is a large hydropneumothorax and there is collapsed consolidated right middle lobe, large subcutaneous emphysema as well. And on the subsequent slides, you can see there is a peripheral type of fistula, and on this coronal better seen, you see the distalmost part of the right middle lobe bronchus communicating with this large hydropneumothorax and also large subcutaneous emphysema is noted. And the patients who underwent endobronchial valve placement for right middle lobe bronchus, and as you can see clearly with those arrows, you can see the endobronchial valve placed in the distal right main bronchus, and also on these images. On the coronal images, you can see how the valve looked like in the right middle lobe bronchus. With that, let's turn on to endobronchial coils. What are they indicated for? Basically for homogeneous and heterogeneous emphysema. Complications are none yet reported. Again, let me tell you, these are in the clinical trial phase in the United States as of now. Let's take an example of endobronchial coils. What do you see here? Patient has emphysema, as you can see, flattening of diaphragm and hyperinflated lung fields. You see question mark shaped metallic densities which are projecting over the chest radiograph, and this is a CT at the same time. Shows how it looks like on the CT, like 4 dots, and if depending on the plane they are acquired, and also you can see it here and on the left lower lobe as well. This is a CT 3 months post procedure. What you see here is expected atelectatic change in the right lower lobe, and that is expected following this endobronchial coil placement, and that suggests that patient is improving as far as the emphysema is concerned. And these are called as pneumo-RF coil for emphysema treatment, and this is again in the clinical trial phase, but you will see this very often with this trial being approved for clinical practice. How does it work? Let's talk about first of all lung volume reduction surgery, and then we'll go over what are the techniques that can be used. So as I mentioned earlier, endobronchial valves are one of the types of lung volume reduction surgery, and the goal of this procedure of lung volume reduction is to reduce air trapping within the emphysematous area of the lung, and thereby it will decrease the regions that are not contributing to gaseous exchange. So bronchoscopic techniques that are used for lung volume reduction surgery would include blocking devices, that is one-way endobronchial valves, as we saw. Then they will include reversible non-blocking devices that we saw on the more earlier slides. These are called as coils. And then irreversible non-blocking techniques like vapor ablation, drug-eluting, airway bypass stents, and polymeric adhesives. These are the images from the literature just to show you what are the stent look like, which are used for lung volume reduction surgery for homogeneous emphysema. And this is a duck-bill endobronchial valve. We are using this at our institution for lung volume reduction via bronchoscopic approach for heterogeneous emphysema patients. Coming to the ablations. So ablations basically includes argon beam coagulation, YAG laser ablation, electrocautery cryotherapy, foot dynamic therapy, and we are seeing this very common these days. They're used for endobronchial tumor and for bleeding sites. Complications related to that would include injury to airway, hemorrhage, and electrocution. Let's take some examples of ablation. This is a patient with tracheal papillomatosis, and as you can see, there is tracheal narrowing and nodular thickening of the trachea. For this, patient underwent argon beam coagulation, cryotherapy, and balloon dilatation. And as these are the images from bronchoscopic approach, which shows pre-ablation tracheal papillomatosis, patient underwent ablation, and then subsequent post-ablation bronchoscopic images, so suggesting successful treatment. The way it works is through the principles of electrocoagulation, and what happens with argon gas and the high frequency electric current, they are directed at the target tissue to cause coagulation via bronchoscopy. And the major indication for the argon beam coagulation are typically papillomatosis and hemoptysis and hemorrhage. Coming to another procedure via endobronchial approach is cryotherapy. One thing about it is another type of ablation technique, but it has delayed effect. And these are the images from the cryotherapy, which shows pre-cryotherapy, during cryotherapy, and after cryotherapy. Usually balloon dilatation is performed, and the final images shows that there is improvement in the patency of the trachea following cryotherapy procedure. So let's identify the procedure that is done for endobronchial carcinoid in this patient. This is 76-year female, and this procedure is done for unresectable carcinoid for palliative purposes. This is a pre-procedure coronal CT. Right main shows that there is a large right upper lobe carcinoid tumor which is extending to the right main bronchus, and you can see the carcinoid here on the pre-procedure bronchoscopy image. Post-procedure coronal CT shows that there is improved patency of the right main bronchus following a procedure, and as you can see on this endobronchial procedure here on the endobronchoscopic approach image, and patient underwent basically ablation of this tumor in the main bronchus and debulking. So this highlights the importance of CT in pre-procedure planning and post-procedure imaging of patients with endobronchial lesions with large masses for palliative purposes. Let's take another case of very interesting application of endobronchial approach application. This is a 36-year-old female with severe refractory asthma. What do you see? This is CT which is obtained 1 week after the procedure. What we see is the peribronchoascular nodular opacities and atelectatic changes in the left upper lobe. So what is the procedure performed? If I tell you these findings in the lungs had resolved 2 months later, so this is basically a bronchial thermoplasty, which is sort of an ablation procedure for patients with asthma. What you see here is that this finding did resolve on 2 months CT. So how does this work? This works through the principle of radiofrequency ablation, which causes induced damage to the airway smooth muscles, and however subsequently the mucosal of the bronchus regenerates with this procedure. What happens is you treat the both upper and lower bronchi, but not the main bronchi. It causes remodeling of the airway and targets the bronchial hyperresponsiveness. It is basically adjuvant therapy for drug refractory asthma. That brings us to another topic of stents, which are tracheal and bronchial stents, and the indication for that would include airway obstruction, tracheobronchomalacia, fistulas, post-obstructive pneumonia. Complications related to these stents would include migration of the stent, granulation tissue formation, mucus plugging within the stent, hemorrhage, tumor ingrowth within the stent, and collapse of the supplied lung. Let's look at the type of stent and why certain stent may be difficult to identify on the radiograph. This is a silicone stent, cylindrical and Y-shaped, which can be difficult to identify on the radiograph, but then metal stents are easy to identify, and these include balloon dilated and self-expanding metal stents, as you can see on this image. Let's take an example of the indication of stents. So as you can see here, patient has irregular thickening of the esophagus, and this is a 64-year-old man with dysphagia and cough, and there is a communication of the thickened esophagus with the trachea, suggesting the case of a fistula. Subsequently, patient underwent stent placement in the trachea, and that communication was taken care of, and patient did improve symptomatically. So there plays the role of this airway stent for treatment of tracheostomy fistula. Another indication for stent is cancers, which can cause narrowing of the airway, as in this case, 66-year-old man with small cell lung cancer causing tracheal stenosis, as you can clearly see on these images, and that is secondary to mass effect from this lung cancer and mediastinal adenopathy. Patient successfully underwent balloon dilatation and stent placement, and we can see that on those bronchoscopic images. This was the area of tracheal stenosis. Patient underwent balloon dilatation and aero stent placement, which is a metallic stent. Another application of airway stent, but in this patient with right upper lobe non-small cell lung cancer causing golden hair sign from the central obstructing tumor, we can see there is a stent in the trachea and in the bronchus intermedius. And the stent in the bronchus intermedius is placed for aeration of the right middle and lower lobe lung parenchyma. This is a complex case of roll-off airway stent in patient with bronchopleural fistula. This patient underwent right upper and middle lobectomy, which was subsequently complicated due to bronchopleural fistula and empyema development. As you can see on this coronal image, patient underwent endobronchial valve placement, and you can see on this insert image here, the valve was placed. But the pneumothorax and bronchopleural fistula did not improve that drastically with this. So, patient to maintain the airway patency, patient also underwent a stent, Dumont stent placement in the bronchus intermedius, and patient had EBUS procedure, as you can see, with extra pleural pectoral flap, and there is a gauze for packing, and that did improve the bronchopleural fistula and take care of the empyema. Volumetric reconstruction images demonstrate patency of the Dumont stent here. Let's take another example of the airway stent, which is in cases of tracheomalacia. Patient had congenital tracheal fistula repair and subsequently developed tracheomalacia. Initially, they tried to place a Dumont stent, but due to airway edema, it was not successful. So they did place a metallic stent, but which was subsequently replaced with Dumont stent. And as you can see, metallic stent is seen on this image. You can clearly see it, but the Dumont stent on this fluoroscopic image is still difficult to identify, and that is because of its silicone nature. And again, on this Dumont stent is difficult to identify, and the CT from the same patient at the same time shows that the Dumont stent in fact had migrated to the right proximal part of the right main bronchus, and this had to be taken care of by intraoperative removal of this stent. This brings us to another topic of the airway stent, which is in patients with tracheobronchomalacia. And as you can see, there is a Y-shaped stent in the trachea with limbs extending to both main bronchi, and you can see that the posterior aspect of that stent is flat, and that is due to a particular reason. And what we see here is this is how the Dumont silicone Y stent looks like, and this is a dynamic type of Y stent. And in this patient, the dynamic Y stent was used, and this is endobronchoscopic view of the Y stent, which shows defect in the posterior tracheal stent membrane, and that is normal finding here in these patients. So how does it work, and what are the indications for this dynamic Y stent? It is basically used for central airway obstruction, which is due to malignancy and which involves the carina. Again, it can be used for tracheobronchomalacia patients, and advantages of this is it mimics the normal tracheal anatomy with D shape and has still struts over the anterior two-thirds of the stent, and which mimics the tracheal cartilage. There is less risk of friction and obstruction as there is improved mucus clearance with this dynamic Y stent as compared to the normal type of Dumont stents. Let's take another procedure that was performed in this 72-year-old man with metastatic skin cancer. What we see, patient had metastatic disease to the bronchus intermedius, and the stent was placed, but while trying to remove the stent, patient developed bleeding, and there was a procedure performed to control that bronchoscopic guided procedure. And as you can see, the patient underwent an endobronchial balloon placement in the bronchus intermedius, and we can see the image how it looks like. And we'll go over some of the complications that can occur with the airway stents. So this is a 67-year-old female with metastatic breast cancer and had left lower lobe collapse due to a tumor. Basically, what we see, the stent was placed in the left mainstem bronchus, but if you see, it's not aerated and there is soft tissue within that. So that is a complication, and it is hard for imaging to differentiate whether there is mucus secretion or whether it is tumor. So basically, it was a stent which occurred due to tumor in this patient. Let's take another example of the airway stent. This is a 21-year-old female with granulomatous polyangiitis. What you see here is the stent in the left main bronchus has migrated distally and had adjacent collapse of the left lower lobe and mediastinal emphysema. That is a complication of the stent. Patient had, therefore the stent was removed, and we found that this opacity of the stent was due to blood. and on the bronchoscopy it shows there is a mucosal tear due to the stent placement. Another complication of the stent is stent migration. This is a 72-year-old man with a left upper lobe lung cancer and which was extended to mediastinum and causing narrowing of the left main bronchus. So for the treatment point, the patient underwent radiation and laser ablation, and also patient underwent stent insertion. Following treatment, the tumor did shrink and the stent migrated in the carina, and that has to be removed to prevent further complication of the right lung in this patient. To bring on the last slide, we have fiducial markers which are now being used by bronchoscopic approach. And this is a 68-year-old female with fiducial markers placed during procedure for assessing ground glass nodule. And these were placed by a bronchoscopic approach. We see one fiducial marker in the left lower lobe, other was quite low, probably in the pleural cavity, and as you can see, it is almost abutting the spleen, but it is in the pleural cavity, in the left lower pleural cavity on this second CT, on the CT images, and this is a dropped fiducial marker. This was placed by a bronchoscopic approach. So where do you use the fiducial markers? These are used for stereotactic radiosurgery for the purpose of tracking. And when do you use stereotactic radiosurgery? It is used to treat early stage non-small cell lung cancers if the patient is not a candidate for surgical resection. Generally, as I mentioned, they are placed via percutaneous CT guidance, but nowadays increasingly we are seeing them being placed via endobronchial ultrasound. With that, I would like to summarize. In last 30 minutes, we touched based on the indications of common and uncommon endobronchial interventions and various devices that are being used these days. And we should be aware of the important imaging findings related to these procedures to provide the best patient care. And CT is finding increasing role in planning and post-procedure assessment of these patients. These are my references. And with that, I thank you. If you have any questions, please let me know. Based on that, what we see following this procedure, the clinical team and the bronchoscopist will decide if the patient still needs a bronchoscopy for this question being raised. Is there any other question? Okay, bye.